Behavioral Health Today, a podcast by Triad Behavioral Health, covering trending topics in behavioral and mental health. This podcast is designed to share unique and relevant topics occurring within the world and our communities and bring them a mental health perspective.
Welcome to Behavior Health Today, and thanks for joining us. I'm your host, Dr. Graham Taylor, and I'm excited about our podcast today, which will be talking about the relationship between behavioral analysis and psychology, and the way these two professions can work in a collaborative and complementary way. Joining me on this topic today is Kathleen Stengel and Dr. Greg Alberts. Kathleen is a board-certified behavior analyst and the CEO of Neurabilities Healthcare. Kathleen has worked in the field of applied behavior analysis for over 20 years, with her major area of clinical interest consisting of the administration of treatment development for individuals with developmental behavioral issues and autism spectrum disorders. Greg is a neuropsychologist and director of neuropsychology services at Neurabilities Healthcare. Greg has 30 years of experience in the areas of clinical psychology, forensic psychology, and in neuropsychology. Kathleen and Greg, welcome. So nice to have you with us today. As we enter today's topic, we know that both psychologists and behavior analysts are both involved with children, working to determine their emotional, their social, their family, and school situations that impact their behaviors, with the goal of both professions helping children improve their interactions with others. We also know that there can be some overlapping by behavior analysts and psychologists and the services that they provide, depending on the needs presented by each of the children that they're working with. As you consider these two professions, I would love to hear each of your stories around your professional path and how it's led you to this current place that we get to meet with you and your involvement with Neurabilities. Please tell us your story.
Thank you, Graham, for that introduction. You know, as we said, I've been doing this for about 30 years. Going back to my graduate school training back in the late 1980s, I did my doctoral PhD work at West Virginia University in Morgantown. I don't know if you know about WVU, but at the time, and I think actually to this day, it's a kind of a rigorous behavioral program, certainly for ABA. Their PhD program is in the top tier of programs across the country. I obviously was in the clinical program at that time, but the influence of that behavioral program really affected students, I think, in the clinical program, the developmental program, and some of the other tracks that were available at that time. So with that said, my learning class that I took at West Virginia was taught by Andy Littell. Andy is a thought leader, pioneer in the field of behavior analysis. And I was fortunate enough at that time to really work in an operant lab as part of that class, looking at schedules of reinforcement as it affected the behavior of pigeons in this case. So I had, a nice foundation back in the day in terms of, rigorous kind of behavioral training and so on. But one of the challenges for me at that time as a clinical psychologist or clinical psychologist in training and the culture there at West Virginia was that there wasn't a lot of attention, or actually much attention at all, played to thinking, played to cognition. Much attention wasn't, given to emotional kind of processing and the like. And in fact, there were occasions if you actually said cognition or cognitive, sort of in the wrong peer group or in the wrong context, you probably wouldn't end up getting invited to the beanery for beers on Friday night. So if they gave you a pass, if you got that invitation, you probably would end up sort of paying for your colleagues or paying the bar tab. So it was an interesting environment to develop as a clinical psychologist at that time, sort of growing up a little bit with some fear of maybe saying the wrong thing. So subsequently, I did my residency and a postdoctoral fellowship in behavioral medicine at Brown University, and decided then after a couple of years to respecialize in neuropsychology. So when I was at Brown, I was working in the Department of Psychiatry and Human Behavior. So it was a little bit more flexible. You could let your guard down, talk about cognition, talk about emotion, and so on. So then I decided to respecialize, and I ended up down here in southern New Jersey, where we're at today, and worked as a postdoctoral fellow in an organization called Bancroft. And Bancroft, if you've not heard of it, has been around for about 150 years or so. It's a residential program, specializes in working with folks with developmental disabilities, autism, brain injury, and so on. So again, back in the early 1990s now, in this postdoc, my mentor at that time, a neuropsychologist by the name of George Neiman, had as his mission and his assignment really to try to approach and integrate behavioral psychology with neuropsychology. Okay. So George at that time had hired a couple of renowned behavioral psychologists, Steve Luce being one of them, Terry Page being another, a handful of other well-recognized behavioral psychologists, behavioral clinicians. So I then sort of found myself back in an environment where I had to be careful about what I said. So I was really forced to, try to make this relationship between colleagues who look upon, human behavior and psychological functioning somewhat differently, had to kind of make it work. So, I spent another couple of years living in fear again, but the outcome of that sort of relationship development culminated in maybe a half a dozen presentations, lectures, workshops that we did again back in the 90s at ABA, Association for Behavior Analysis, Association for Advancement of Behavior Therapy, a few other national and regional conferences, where we really talked about how these two disciplines can get along, how we can recognize each other's strengths, how we can capitalize on sort of the areas that we don't cover in terms of our assessments or evaluations, and how we can really kind of put our heads together to really optimize functioning in the clients, the students that we were working with. So 20 years, 30 years later, I'm now obviously back in an environment with Kathleen and a number of other recognized behavior analysts. So we're trying to make this work as best we can.
Really good. What a path. I love the idea of being able to find out what each brings uniquely in a contributive way to really have kind of a nice opportunity to help people in a multidimensional way. Kathleen, what's been your path? Love to hear about that as well.
So literally on the other side of the fence, as an undergrad, I was immersed immediately into behavior analysis in an operant lab where we were the ones pointing and saying, don't say cognition, don't say cognition. So I was trained as an experimental psychologist under Phil Heinlein at Temple University, and he is what I would consider to be a radical behaviorist, direct descendant. We studied, behavior in and of itself was an interesting variable, that could be studied. And I often found that we had our own little kind of niche society. Actually, we did have a niche society at Temple. Specifically, we had something called the Black Scorpion Society for Behavior Analysts, or budding behavior analysts. And Black Scorpions in reference to a paper Skinner once wrote in response to Chomsky's paper. So, so obscure, it would have never been even on a Jeopardy question. So we had this little secret society where we would have beers and we would talk behavior analysis and we would immerse ourselves in the science. So I fell in love with the science first before anything. And then I had the opportunity to work with, and Greg and I, interestingly enough, crossed paths through some of our mentors. Dr. Steve Luce, he was renowned in our area, worked with him at a number of different facilities, but I had an experience in an inpatient facility for kids with developmental and behavioral challenges. So much so that it was inpatient and very, very intense. But the reason that they got in, and it was called the Seashore House at the time, was that the behaviors were so bad they could not live in even a residential facility. So it was urgent need, self-injurious behavior, very, very intense, and pediatric. Okay. So in that dynamic, it was a great experience for an undergraduate intern pushing in and getting to work with some of the greats in our field, Dr. Tim Vollmer, where we would do behavior analysis. And in 2 weeks, we would find the function of a behavior and we would immediately see an immediate result of the work. There is nothing better than that, immediate result. So of course I went to grad school, studied behavior analysis. In the Children's Seashore House, we got to work with psychologists, but it was different. It was interdisciplinary in some respects, but definitely siloed. The behaviorists would have their clinical rounds, and the psychologists would have their clinical rounds, and then the doctors would have their clinical rounds. And it was almost like we were talking about different aspects of the elephant, three blind men feeling around. And it wasn't until I went into grad school and started to work at the university setting where we got to interact with, many different psychologists, different, organizational behavioral management is one of my areas of interest. And I got to work with psychologists there and behavior analysts who were working there because the Department of Behavior Analysis was not in the psychology department. It was its own department in the Department of Community Service. It was almost segregated on purpose, which forced us to working more collaboratively together, especially for the population we were working with, which was children with autism.
Okay.
So that was my first taste. And when I finalized and finished grad school, I came back up north to, Pennsylvania, New Jersey area. And fast forward, I think nobody's really doing that, pulling it all together. It's
Yes.
almost like the systems, even themselves, are set up to have a psychological assessment that's treated separately,
Right.
medical intervention that's treated separately, behavior intervention treated separately. So it even reinforces us not speaking to each other. And the only type of places that ended up doing it right were exactly like, where Dr. Alberts came from, which is Bancroft, which that group of individuals actually created CNNH, which eventually became Neurabilities, which is where we're both at now. And so it's an interesting path that led us both to the same conclusion, I would say. It's that interdisciplinary model that pulls it all together to really look at the patient holistically from every angle so that we're seeing it from front to back.
It would seem like that would make the most sense rather than having everything kind of compartmentalized and kind of not reaching across the proverbial aisle. What allowed, do you think, bringing this in a more multidisciplinary way? And what was that like as that began to happen in your guys' history?
I think from my perspective, Graham, it reflects, I think, the leadership, the clinical leadership.
Yes.
Certainly the organizations that I've been involved in. Our physicians, our neuropsychology leaders and so on really have to kind of drop the ego, drop the attitude.
Exactly.
And I think recognize that we all have limitations in terms of what we can explain or understand or predict or treat in terms of these, mostly complex conditions that we're working with.
Yeah.
So I think it really kind of starts obviously from the top. And then people obviously have to see that it works and have to, appreciate and respect the perspective, the colleague, the peer, whomever it might be. But it's, oftentimes kind of boils down to relationships and, being willing to sort of be open and communicate and collaborate and, see what happens.
Really good. Kathleen, what was your sense that allowed it to come together that way and your experience of that?
In my experience, I think it's when people have the right motivation for what they're doing. I think everybody who I work with right now, and I couldn't be more excited on a regular basis of the amount of, amazing clinicians that we have, but every one of them came with the same motivation. I want to help someone. I want to be able to help as best as I can. And if I can't help, I'll find you someone who can help, and we're better together than apart. And I think it's that first motivation. But one thing that did help, and I will say that it's within the last 2 years working with Dr. Alberts, I've noticed that the language that each individual clinician, whether it's a behavior analyst, a physician, or neuropsychologist, et cetera, we use our own sets of language. We describe things, and we might be describing the same exact things, but we describe them with different words. And behaviorists are very much, they call it behaviorese, where we use language very succinctly. And the same happens with the neuropsychologists. One thing that happened when I got here and Dr. Alberts has done is he's actually able to translate between the two.
He's got a little bilingual, huh?
He's multilingual, because he's able to take the information from the neurologist, then the psychologists and the behavior analysts, and say, oh, we're all talking about the same thing. Here, let's put it out there. So when Dr. Alberts speaks about leadership, I think that's what he's speaking about. He's able to effectively communicate across disciplines, number one. But I would say that the system still is not set up for us to work together from a funding standpoint. So it really is the drive and vision of the amazing clinical staff that has to really push forward and say, yes, let's come together, because the world wants to pull you apart.
Yeah. I love that idea of being able to come together like that. I agree with Greg, what you're saying too, that kind of requires a little bit of the death of the ego, putting that aside and looking to what is it we all have in common and what is it we all have as a shared goal? And then how synergistically can we bring all of our unique talents and gifts together to provide the best possible service for those that are coming into our program? Talk about what kind of folks come into your program and how, given your backgrounds, each of you finds a really contributory way uniquely to collaborate in that patient care. Tell me about that.
So first and foremost, we were founded, Neurabilities specifically was founded by this idea of multiple disciplines coming together under science. Yeah. But our medical physician is actually a neurologist. So neurology is at the forefront of most of what we do and has always driven the population of traumatic brain injury, developmental disabilities, seizure disorders, many different neurological issues, which is a very, very large umbrella. More specifically, the team that was pulled together initially and has since developed is really known for individuals with developmental disabilities. And we are in Pennsylvania and New Jersey, and there is a very large population of individuals with autism, and specifically in the state of New Jersey. It's one individual and 34 children who are now classified as having autism. In Pennsylvania, the numbers aren't the national, they're actually more. It's along the lines of 1 in 34 to 1 in 50, depending on where you look at the data. So there's a lot of kids and adolescents and adults in need.
That's a high number. Yeah,
that's a very high number.
Yes, it is.
And they're all, issues of development and neurological conditions. So there's a high amount of need, and those are the patients who come to us. They come to us from 18 months old all the way through adulthood. We get a very large population, and we're very lucky to be able to serve the population, but it is not just one discipline. They come in initially for neurology, and then they're referred for further testing, because the neurologist needs to not only understand the functionality of the brain, but then also needs to understand, performance. And that's typically when it trips the switch to say, okay, let's see what level of performance we have, either as a baseline or as an ongoing measure. And that's when it goes into Dr. Albert's hands.
Very cool.
So, as Kathleen indicated, we have kind of our point of entry for most of our patients, most of our clients, comes through our physician staff. So those are neurologists, they're developmental pediatricians, they might be nurse practitioners and so on. And typically, these are complex cases, on the surface, certainly, and oftentimes sort of underneath the surface. So as extensive of what we call kind of clinical profiling of the patients that we see. So, that'll involve a neurological evaluation, a physical examination, laboratory testing. Frequently, we do EEG studies looking at electrophysiological activity of the brain. We do, obviously, our behavioral assessment staff, do their piece. The psychology and neuropsychology staff as well make their contribution, and sort of representing the neuropsychology approach here. We don't just do IQ testing. We don't just do academic testing. We don't just do memory testing, executive function testing, and the like. We try to, not approach these cases as subjects amenable to testing, but we really try to gather both objective data, look at family history, do sort of a family tree in terms of potential genetic contributions that may be playing out here. All of these individuals that we see live in a context. Some are wards of the state, some are living independently, and so on. So our mission really is to gather objective data, medically, neurologically, biologically, behaviorally, but not sort of miss that piece about the context in which they were either raised or currently living, because that piece also is oftentimes helpful in understanding and explaining behavior, and also obviously intervening in behavior. So we don't want to kind of miss the piece of the broader sort of psychosocial context in which these folks present to us.
That is an extremely thorough approach, and how beneficial to understand somebody so holistically in all their different areas of their lives. Give me a sense. You said these are complex cases. Paint a picture for me of somebody coming in and the level of complexity that you folks are beginning to kind of tease apart and then find a way to bring back together so you can address it professionally. Give me a sense of the complex nature of the cases, please.
Yeah, so we are actually in the process right now of trying to kind of sort out a clinical presentation and most effective management for a teenage boy who has started out in services with our behavior team. So this person did not come through our medical staff or neurology or developmental pediatric staff. So our behavior team had reached out, set up a meeting, sort of an interdisciplinary conference. So the essential issue with this youngster, this teenager, is that he's, I think, 13 or 14 years of age. The behavior staff started working with him, really targeting social skill development, trying to promote, conversational exchanges that went beyond one or two turns, improving eye contact, and sort of more of a traditional kind of social skills-based intervention. And as it turns out, some other target behaviors started to emerge, some self-injurious behavior, elopement, kind of threatening verbalizations and the like. So it sort of evolved from what we thought was a fairly straightforward case to one that, is sort of perplexing, certainly to our behavior staff, complicating this traditional social skills type intervention that we're trying to deliver. So we're in the process of trying to work up this particular patient. So, some of the suspicions that we have is that there's probably an underlying anxiety disorder.
Okay.
Sort of came across that as this youngster is washing his hands multiple times a day to the point of abrasions and bleeding. He's reporting hearing voices or having conversations in his head that he doesn't feel that he's under control. He is hoarding things in the household. He is refusing to drink water on occasion out of concern that he might be poisoned. He's having sort of staring episodes. There's some issues with contamination concerns that coincide, we think, with some of the hand washing. So now we've got a youngster with autism, with a diagnosis of autism, and a history of ADHD and so on, that now seems like there's much more going on.
He's really struggling.
And under the surface.
Yeah.
So our mission with him at this point is to have him seen by our medical staff, do laboratory studies, blood work, and make sure that there aren't any underlying medical conditions. We are going to evaluate him neuropsychologically, and part of that process will be a more extended kind of obsessive compulsive evaluation or administration of questionnaires and inventories and some direct observation. And we're going to take that data, and actually I should add too that we're going to probably try to secure permission for an EEG study in light of some of these staring spells that this individual has. There's some involuntary movements and involuntary behaviors that could be tics, could be seizure phenomena, and so on. So what started out as a basic social skills kind of case has now evolved into something much more complex and much bigger. So that's kind of our mission at this point, is to try to sort out what is environmental, what's biological, what might be kind of called neuropsychiatric, and sort of put our heads together and try to develop a treatment plan that certainly is going to continue to involve skills training, but may also involve what we call exposure and response prevention interventions, which is validated treatment for OCD. Depending where we get with that and the patient's capacity to participate and to tolerate, sort of increasing levels of stress, we might look at possible medication interventions. And, much of this assumes certainly that his EEG is normal and that some of these behaviors aren't driven by electrical anomalies and the like. So, we're just kind of starting the journey with this particular patient, but it certainly represents many of those that we see here where, we start out with something, at least on the surface, that seems pretty straightforward, and kind of the deeper you look or the longer you spend with them, the more complicated it gets, and then sort of the mission begins.
Really good. And Kathleen, I saw as Greg was talking, you're kind of sitting there as well and kind of some familiarity. Give me your thoughts as you're listening to this presentation and kind of the complexity of it and your thoughts around it.
So from the behavioral perspective, typically, if they don't come in with us, meaning if the patient entry point is at the behavior aspect, it's usually one of two different ways. Either there's very, very significant behaviors that are just out of control and we have to push immediately in, or it's something like, something seems to be a little bit not right. And this particular patient that we're referring, very aware of them. He's been on the behavioral clinical rounds. And as we started to work more and more, progressively more information came out, trickling 1, 2, 3 at a time. And the behaviorists here, and actually it's part of our ethics, we have to stop when things start to change. We have to say, we need to rule out some medical variables. Lucky for us, we were able to actually rule out some of those medical variables before we started intervening with intense behavior interventions without understanding all the facets. Meaning, if you just look at some of the behaviors out of context of all of the other aspects that Dr. Albridge just spoke about, some people would just hone right in and say, oh, okay, we're washing our hands too much. So the function of that is because we're providing attention. So let's ignore, or, some, molecular type analysis of the behavior that doesn't account for the whole individual. You're going to miss an entire aspect. The staring off spells were operationally defined as a focus issue. So there's a difference of talking about staring off and possible neurological activity versus focus. So our behaviorists, luckily, they very much hone in on that, and they start taking data, and they were able to bring that to our interdisciplinary team to say, hey, listen, he's staring off into space, and they're saying it's not focused, and the team of the neurologists and neuropsychologists immediately said, okay, well, let's roll these different variables out. So that hand in glove approach, we don't have outcomes yet, but I know that mom is feeling a lot more settled, that we're not having such outbursts, and there's at least a path towards an answer for this journey that she's on, because it's very hard on these families.
Yeah, that is a really complex picture. And I love the idea of being able just to tease apart and get very specific as to what this really is, not just kind of lumping it in because it's easy to kind of see on the surface, but to kind of mine down into really specifically, what is it that we're dealing with here? And then what kind of treatment approach can we bring to it? With the level of complexity that folks deal with at times, it sounds like you've been very intentional in coordinating this multidisciplinary approach at Neurabilities, such that each profession has a specific and impactful contribution to patient care. If you look forward in this young man's case, although it's not resolved at this point or where he will be at some point, paint a picture of what you might anticipate him coming out with after working with you folks over a period of time. What's he going to look like, do you think?
Yeah, let me make a quick comment here about that, Graham. Again, we're beginning this process, as you know. The things about this youngster's behavior that are concerning are for multiple things. One is episodes of elopement. So, what's driving this impulse that he has to leave the household or potentially dart into traffic? Is that an impulse control disorder? Is that a panic attack? Is that, some other, influence like that? So we anticipate, through this process that we'll be able to better reduce those episodes, teach them some self-regulation skills. If these indeed are panic attacks driven sort of by an underlying physiological overreactivity, then, maybe medication treatment will be indicated, maybe some mindfulness activities for this individual who has autism and ADHD but is quite high functioning. Yeah. So beyond the elopement, I think there's self-injurious behavior that is sort of incidental to the excessive hand washing and so on. So that raises certainly some concerns about tissue damage and so on. So we want to see that, minimize the verbalizations that have, been concerning to parents, to staff, and the like that may have an aggressive nature to them. We suspect that that's probably driven by some of these OCD features and some of the impulsivity. So, if we can, get a handle on all of that stuff, we anticipate that this kid is, going to be on a path to more active participation in school. It's interfering certainly with social relationships. So it's going to give us an opportunity to targeting the social skill deficits and conversational deficits that he has. And again, the outcome there would be, improve peer relationships and, generally a sort of a better adjusted kid who's not, uncomfortable, who's not stressed, and who's, overall just sort of enjoying life a bit more.
What a hopeful picture for this young man, for this family. That has hope all around it, doesn't it? That this is what we can do with the team that we're bringing together. Kathleen, you want to, I know we're kind of winding down on our time, but anything you want to contribute just on that last part of what you might anticipate in addition to what Greg is sharing with us?
So I know that on the skill development end, he's already has an analysis on where he himself wants to go. Oh, so good. On the behavioral end, we're really trying to interact. He's, becoming an adult soon. He's an adolescent. And it's where do we want to go? And our job is to try and pull that out from him and see, yes, there's things that we want for him, but at the end of the day, what do you want? And he's able to tell us that he wants to participate, and he is active and wants to move towards the path of independence. And that's huge for us. So if independence is my goal for every kid, for every adult, for everyone. And it's a matter of how then should we define that, and we're going to allow him to work with us on that, and hopefully this entire team together we can give him a path towards what he wants to be.
Really good, really good. Yeah, there is hope all around that. As we wind down today, for those that are listening, can you guys give us some resources that you'd recommend for better understanding folks who are kind of experiencing this in their families, and include some information about Neurabilities and how folks might get in contact with you guys and your services.
Sure. So our website has a lot of very valuable resources from all disabilities, from autism all the way through Tourette syndrome. And so we have resources on our website, which is www.neurabilities.com. And it's NEUR abilities.com. It's the brain and behavior together.
Very good. Greg, from your side, any resources you might add to us?
No, I would just reinforce what Kathleen has said, Graham. There are behaviorists out there who are wanting to make these relationships work and, in benefit of the clients that we sort of mutually serve. And I think it's important really that we think about reading the other disciplines' journals, logging on to those webinars, kind of get out of those silos as Kathleen had referenced early on in this conversation. There's a lot to learn that we have to offer each other and the like. So I think, it's a matter of kind of stepping out of your zone and, checking out other people's content and publications. And there's a lot to learn out there.
I agree. That's where it can really get exciting when we begin to professionally share in each other's sandbox, and come in and enjoy it and get curious about it and interested. We know mental health in children really is paramount to their success later in life. And I see psychologists and behavior analysts and other professions that get to be a part of this. Our medical colleagues, each has a unique professional role in aiding in these children's success. And I love the idea of early identification, early intervention. And as both of you have described, there can be a great collaboration that can occur and some really important treatment outcomes reached for these young people coming to see you. So I really appreciate both of you, Kathleen, Greg, being with us today. Thank you for what you're sharing, and it's been great to be with you.
Appreciate the time, Graham. Thank you so much.
Yeah, thank you, Graham.
That's been my pleasure. And always thank you to you, our listeners, for joining in, and we will look forward to seeing you next time on Behavioral Health Today.
We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Tried Behavioral Health Network, all rights reserved.